Okay, now on to human bites. The human has a lot more bacteria, viruses, etc. in their mouth, even more so than a small animal's mouth. So while we don't think that human bites are all that bad, any sort of human bite that has actually broken the skin has the potential to be a very serious injury because um, you can get a serious, rapidly spreading infection from it. So, emergency treatment is really pretty straightforward. You want to apply a dressing, immobilize the area with a splint or bandage as needed, and then provide transport. Burns account for approximately 3,400 deaths every year. They're among the most serious and painful of all injuries. A burn occurs when uh, a body or part of the body receives more radiant energy than it can absorb, which ends up resulting in injury. For those with a burn, it can come from several different sources. So it can be a heat or thermal burn, toxic chemicals, or it can be from electricity. Although the burn may be very apparent and you pretty much can tell that it's there, if anything, you can definitely smell it. Um, Make sure that you're performing a complete assessment to make sure the patient doesn't have any other serious injuries. Burns are a massive distractor because they are so painful. So we need to just make sure that you don't miss anything. And people that have chronic illnesses, patients that are older or younger, are more likely to experiencing shock from a burn. So keep that in mind as well. For the pathophysiology, so burns are soft tissue injuries. They're created by one of those various sources that I just mentioned. Thermal burns can occur when the skin has been exposed to temperatures higher than 110 degrees Fahrenheit, um, but that's based on an average. Younger kids are definitely much more susceptible to burns. You can leave them in that under 110, but if you leave them in there for a while and it maintains its heat, then that can cause injury to them. The severity of your thermal burn correlates directly with the temperature, the concentration, the amount of heat energy that's possessed by the object or the substance, the duration of exposure. Keep in mind that burn injuries are progressive. And so the greater the heat, the deeper the wound, even though you can't see it. If they were exposed to high heat, it has gone deeper in. People naturally limit the amount of time that they're exposed to heat because of obviously our reflexes. But if a person is on fire and they're trapped unconscious, obviously your reflexes aren't going to save you from that. So complications of burn. So first and foremost, when you have a burn, that mechanical barrier ends up being destroyed. So you end up having high risk for infection, hypothermia, hypovolemia, and then just overall shock. Burns to the airway are super scary because of the swelling that happens as well as the potential for infection. The loose mucosa that's in that actual airway can swell significantly, leading to complete airway obstruction. Circumferential burns, circumferential means all the way around, of the chest can actually compromise breathing because it reduces the pliability of the chest, and all of that swelling is only going to go so far, and then it's going to start compressing inward. Circumferential burns of any extremity can lead to compartment syndrome, which then ends up leading to neurovascular compromise and can lead to irreversible damage if not treated appropriately. If you suspect any of these complications, go ahead and get ALS rolling. Burn severity depends on the depth, the extent. Are there any critical areas involved, such as the face, the upper airway, the hands, feet, genitalia? Is the patient younger than 5, older than 55? Do they have any pre-existing medical condition? That definitely tells you that things are more serious. Burns that are over the hands, the feet, or joints can also be considered serious because when they heal, if they have significant scarring, you're going to have loss of function. A couple different categories for how deep a burn goes. You've got, we used to call them first, second, and third. We don't so much do that anymore. We've got superficial, partial thickness, and full thickness. And I'll go ahead and pull over to the picture here so you guys can see. So superficial involves only the epidermis, so that top layer of skin. It turns red, but it doesn't blister. So like a really bad sunburn before it's actually blistered, which you can see there. It's often very, very painful. The partial thickness degree, so now you've got the epidermis and some portions of the dermis. They don't go through the entire thickness of the skin. We don't have any subcutaneous skin affected here. The skin itself typically looks pretty moist, mottled, reddish to white. Blisters are present and you can have pretty intense pain. Your full thickness burns extend through all the layers, may go down to the subcutaneous, may even continue down to the muscle, bone, can affect internal organs depending on the severity. The area is very dry, very leathery. It can range from white, dark brown, or look actually charred. If the nerve endings have been destroyed, which in this type of burn, the majority of the time they are, so the patient really doesn't have a lot of pain over that third degree burned area. It's got areas of partial thickness and superficial around it, and those tend to be very, very painful. But that actual severe charring in the center, definitely not going to cause significant pain. Significant airway burns are very, very, very serious. If you have singed hair in the nostrils or soot around the nose or mouth, if they're hoarse, if they're hypoxic, transport very, very quickly because we have to take control of the airway before we lose it. To try to estimate the extent of burns, there's a couple of ways that we do this. You can use the rule of palm. So it estimates the surface area that's been burned by comparing that area that's been affected to the size of the patient's palm, not ours, patient's palm. And the size of their palm is roughly 1% of their body surface area. Is this an exact science? Absolutely not, but it gives you a good starting point. The other thing would be the rule of nines. So this estimates the extent of a burn by dividing the body into sections. Each section represents approximately 9% of the total body surface area. The only difference with the rule of nines that makes it difficult is that kids and adults, infants, all three vary as to how much equals what. So a lot of times it's going to be more of a guesstimate than, yeah, I definitely have that correct. When you calculate the extent of an injury, only include the partial and full thickness burns. Document that there are superficial burns, but don't actually include them in that calculation. When you're assessing burns, it's very important to classify based on the source of the burn, the depth of the burn, and the severity of the burn. For your scene safety, make sure that you're keeping yourself safe. Make sure that whatever that led to the patient's being burnt is not still there to pose a threat to you. For mechanism of injury, attempt to determine the type of burn. You're going to get a lot of history often from the patient that's going to tell you what's going on. Make sure that there's no other patients that have been affected, and consider the potential for traumatic injury, even if you think the only thing we're worrying about is a burn. And call for your additional resources early. If they have airway involvement or a significant area that's been burnt, they're going to need some fluids and airway control. Primary assessment, that rapid from the doorway scan of the patient, looking for general impression, any sort of clues that can tell you how the patient is doing. We're going to look for our airway and breathing, making sure that we check to see if the patient has had any airway exposure to hot gases or vapors. Again, that's going to be singed facial hair or soot present in the airway, or hoarseness when they're talking. Heavy amounts of secretions, frequent coughing may also indicate that respiratory burn. For circulation, determine how perfusion is with the patient. Cap refill is a quick check for that. Take steps to control any significant bleeding. If they have obvious life-threatening external hemorrhage, go ahead and control it. Treat them for shock. Prevent heat loss. Patients with burns are going to have issues controlling their own body heat. Consider rapid transport for any patient that has an airway or breathing problem, significant external bleeding, signs and symptoms of internal bleeding, or very significant burn injuries. And you may need to get ALS rolling as well. For history, investigate the chief complaint, asking a lot of questions. If they have been in a confined space, just automatically suspect that they have an inhalation injury. Obtain medical history for injury-specific signs and symptoms, any pertinent negatives that you may have. Typical signs of the burn are pain, swelling, redness, blisters, charring, etc. And symptoms may include that severe pain at the injury site. Regardless of what you're trying to do, go ahead and stop the burning process first and foremost, because it will progressively get worse and go deeper. Apply a dressing to prevent contamination and treat your patient for shock. When we're looking at sample history, ask everything that we have to ask, but while we're asking the S portion, you can ask about difficulty breathing, difficulty swallowing, and the presence of pain, in case you didn't grab that during OPQRST. For physical exam, we're going to want to go ahead and take a look at the entire body to make sure that we're not missing something. We don't want to leave anything to chance. So we're going to go head to toe looking for DCAT BTLS. We're going to make a rough estimate using either the rule of nines or the Palmer method to try and estimate the area percentage burned. To try and figure out the classification of the burns, determine the severity of the burns, package the patient, continue to assess the airway over and over and over to make sure that you're not seeing swelling starting to develop. If you are worried about the patient having been exposed to some heated air or vapors, you can always have them open their mouth, examine for burns or swelling on the insides of their mouth, have them stick out their tongue, and keep talking to them. If they're conscious and alert and they can sit there and talk back at you, go ahead and do that, because when their tongue starts to swell, you're going to know about it because you're going to hear them slurring. We'll go ahead and assess the patient's neurologic status using AVPU, pupil size reactivity, and then motor and sensory response. We'll assess the musculoskeletal system, looking top to bottom. If this is an electrical type injury, keep in mind that there's the spot where the electricity entered the body, and there's going to be a spot where it left the body. Just like gunshot wounds, the one that comes into the body, not as bad. The one that leaves the body where the energy finally just blows out, that is definitely going to be the worst one. In the chest, check for any circumferential burns that can impair that normal chest rise. Same with all of the different extremities. We're going to feel all the quadrants of the abdomen to look for anything that is outside of soft, non-tender. We want to make sure that we look at the posterior surface of the body. The patient not being able to see it may not realize that there's something going on down there or back there, and determine an early set of vital signs so we know how the patient is tolerating their injuries at that time. Blood pressure, pulse, and skin signs for perfusion are going to be for sure what we want to look at. Monitoring devices, O2 sat monitor and then carbon monoxide monitor. Remember that the O2 sat only determines that there is something bound, but not what it is, and those that are exposed to fire in confined spaces often have carbon monoxide exposure. So that may read 100. That doesn't mean it's oxygen. We'll continue on in the next.